and there whenever years. I have worked in this beautiful subject. I have enjoyed this beautiful subject, and I will like to talk to you on this beautiful subject. Basically, petroclival meningiomas are the top of the line of skull-based tumors. As we know, petroclival. Can you see my slide?
Sir, I believe, yes, we can now.
Okay. So petroclival meningiomas are difficult tumors. Petroclival tumors are benign. Meningiomas are benign tumors. Petroclival meningioma surgery can give new, benefit of symptoms, and from all these things, patient can recover from all these problems. On the other hand, you can create devastation. You can create deficits. You can create huge deficits, and you can even kill the person. So it is very important that we understand petroclival meningiomas, we understand the nuances of skull-based surgery, and we understand the subject of neurosurgery in general. So this was one of my articles where I said that neurosurgery is an amalgamation of philosophy, technique, and technology. It is not just, oh, I have removed this tumor, and you show pre-operative image and post-operative image and this and that, I'm very happy. What we have to do is, we have to be philosophical. We have to use our techniques to the best of our ability. And wherever technology is there, we have to use the technology. Most important equipment in dealing with skull-based tumors is, of course, a beautiful, good microscope. May not be top of the line, but the person has to be comfortable with microscope. Second most important thing is the drill system. You have to have proper drill. You have to have burr, you have to have diamond burr. And more than anything else, you have to understand the anatomy of that area. So it is neurosurgery is an art. Neurosurgery is a concept. Neurosurgery is a philosophy. And I'm convinced from my experience over the years that if we create a deficit, we will think, oh, this is just 6 nerve deficit. Oh, this is just 4th nerve deficit. Oh, this is just facial nerve deficit. At least the person is moving his hands and legs. But these deficits just disable the patient. They completely demolish the person. And we should understand that patient may come with just marginal symptoms. So we are going to relieve the person of his symptoms, and we should not come out with creating huge deficits. I'm not saying deficits cannot happen in this operation. Deficits happen in all situations in neurosurgery. And this is one of the complex locations, and we have to understand that we can create a complication. On the other hand, we don't go to operate to create complication. We operate to relieve the person of his problems. So in general, we have to understand that all petroclival meningiomas are different like fingerprints. All fingerprints are different. Similarly, all meningiomas are different. Yesterday, in one of the webinars, I was saying, we identify a dog on his nose print. We must know that our pinna, our external pinna, every human being has a different, no two pinnas are similar. No two voices are similar. Voices. No two cerebral sulci and gyri pattern are similar in two individuals. So everything, this difference makes life. Life is like that. So meningiomas are different, not by virtue of its size and location, but also consistency, vascularity, extension, difficulty in surgery, and more important than anything else, the ultimate outcome of meningiomas. Petroclival meningiomas may be, petroclival meningiomas are petroscum and clavus in junction. There is trigeminal nerve at the apex of the petrous bone, which goes in the middle fossa in the lateral wall of cavernous sinus. The tumors medial to the trigeminal nerve are usually labeled as petroclival meningiomas. So they may be small tumors, they may be huge tumors. There may be calcified tumors or ossified tumor. You see, this tumor is different meningioma, different implications, different surgical style, different goals, but this is different. This is, you see, another calcification, extension in the fetus bone, basilar artery engaged, cavernous sinus involved. So this is different style, different aims, different objectives involving the cavernous sinus, having calcification of various types. This tumor is another huge tumor, middle fossa. So pituoclival meningioma essentially are in the pituoclival area. But extension into the middle fossa, into the cavernous sinus is quite frequent because of the relationship. They are neighbors. So extension into the neighborhood, into the cavernous sinus, also into the nasopharynx. So when the tumor, in my estimation, when the tumor is multi-compartmental, goes from one compartment to another compartment, it is behaviorally a little bit more aggressive. Length of the tumor is only in the middle fossa or only in the posterior fossa. They are behaviorally a little bit different. When they are in both middle fossa and posterior fossa, they are behaviorally more aggressive. And when the tumor goes into the nasopharynx, it can be taken as an aggressive malignant tumor, and you can treat them as such. So these tumors involve cavernous sinus quite frequently, carotid artery quite frequently, goes into basilar artery, into the pituoclival area. They can be right in the clivus. So all these tumors are labeled as pituoclival meningiomas or tumors. And many a times they go into the cavernous sinus, they involve the entire clivus, they displace or engage the basilar artery, they involve the confines of the cavernous sinus. Sometimes they go just in the metals dural cave, sometimes they go into the venous plexuses of cavernous sinus. So these are different types of. Quite infrequently, they can be as vascular as this tumor. You see, large vessels, large veins, and this was, of course, meningoperistoma, difficult tumor, dangerous tumor. You must know that tumor is dangerous, but the patient comes with the similar symptoms of headache and all. Patient does not know he or she is having a dangerous tumor. Patient does not want to have a deficit. Patient does not want to have hemiplegia. Patient does not want to have facial weakness. So this vascularity and all is not for that. Patient does not know his vascular tumor. We have to understand and we have to prepare ourselves for eventuality and how to deal with such vascular tumor, how to control bleeding. So this is the very close to the cavernous sinus, very close to the trigeminal nerve, and most close to the sixth cranium. So
Sam, are you there?
Pituoclival meningioma surgery.
Yeah, I'm here. Can you
How
hear
you,
me?
how you doing? Yeah, I can hear you.
Yeah, I'm fine. How are you?
Good, good. I can't see you though. Your camera's not on. Do you want to test it?
In danger. So
1 second.
surgery for pituoclival meningiomas, you see, one is access route. And you know the access route, there can be facial nerve, there can be hearing nerve, that if you're coming from middle fossa, there can be trigeminal nerve. And the sixth nerve, and also the tentorium, there is fourth nerve. So this is a dangerous tumor. This is nerves, but vessels, any single
Working on
damage during this.
Can you give me a minute? 1 second, I'll check.
Yeah, it's at the, what are you using? Are you using a laptop or a smartphone?
I'm using my laptop.
Okay. On the screen at the bottom, there should be.
No, it's showing only audio. It's supposed to show video as well, but I don't know why. I'll go back and I'll come back.
Yeah, good idea. Reboot. Totally reboot. You know what I mean? Turn your computer off.
This is the region of cavernous sinus. This is the edge of the tentorium. This is third nerve. And this anatomy has to be understood very clearly, very fantastically on the basis of dissection, on the basis of cadaver dissection, and not just one dissection or two dissection, months and years and lifetime of dissection. There is carotid artery here in the pituitary. There is greater superficial petrosal nerve or GSPN. There is facial geniculate ganglion here. and there is cochlea here. This picture bone is without any neural or vascular structure, which is called Kawase triangle, as we all know. So we drill the Kawase triangle, we go into the posterior fossa from the middle fossa. So learning the anatomy, learning the art of drilling this area, protection of nerve, protection of carotid artery are so much critical and crucial. So I have been in this journey for several years, and you can imagine. I wrote this book with Professor Kobayashi, and the skull-based part of tumor part was written by me. And you can imagine 30 years ago, and the beauty of this book, if you happen to read this book, is still available. The beauty of this book is the whole book, my part at least, is monographic, means I have not used any other reference except my own work. 30 years ago, I had that power to use only personal references. So that is the beauty of this. It is a monographic book. And we must read, I must get hold of this book. And if you see the cover page of this book, I was involved in drilling. And I used to drill, I conducted workshops, several workshops around the world, including Japan on so many instances, in China, in Singapore. Many situations I conducted. My first workshop in Japan, in Shinshu University, with Professor Kobayashi was in 1992, where I demonstrated how to use the drill and all those things. And you'll be surprised, when I was drilling and demonstrating, people behind me, including Hakuba, who is one of the foremost in skull-based surgery and who described pictorial approach and orbitozygomatic approach, Hakuba, very famous neurosurgeon. The other person who promoted pictorial approach was Helmet. He was behind me. Kawase, who has his approach on transpictus apex approach. Kawase, and these pictures are still in my library, and they give me such great pleasure when I see Kobayashi was there, and Dr. Fongo, who has now retired, and Ohata, who was a senior professor.
Sam, are you coming in?
They were all there. So essentially, in my lifetime, I used to do a lot of petrous bone drilling, carotid artery displacement, trigeminal nerve displacement, and if you see the facial nerve mobilization and total petrosectomy, this approach was described by Dr. Laligam Shekhar, who was a very prominent skull-based surgeon at that time, and of course still a prominent. And this was the approach which I used to do on a regular basis in my operation theatre, of course not always, and indicated. So we modified our approach to an extent. So orbitozygomatic approach means orbitozygomatic. You use zygoma resection to pull the temporalis muscle down so that you get an additional exposure here. So we made an alternative kind of incision. This is a long time ago. I picture also a long time. And we did basal craniotomy. This is the root of zygoma. I didn't remove this is one of the approaches that we described. More than 35 years ago, you must remember at that time, it was too long time. So this is zygomatic arch, root of zygoma, roof of condyle, roof of external ear canal, and we included mastoidectomy. So this was subtemporal craniotomy. And this inclusion of mastoidectomy in subtemporal craniotomy was first described by us in this paper which I'm going to show. So root of zygoma, roof of condyle, roof of external canal, and mastoidectomy. So this was the paper, basal extension of craniotomy for subtemporal middle fossa approach, basal extension. So this is the subtemporal craniotomy, basal extension. This is the condyle, this is the roof of external artery canal, and little bit of mastoidectomy we used to do. I'm not saying in all cases, but in many cases, and I describe this approach. So this was the incision, this was the basal cut, this was the craniotomy. We also described 30 years ago this tentorial dural flap. My book used to go from here, and the knife was placed on the edge of the book, and I used to take like that and made a flap. And I described this flap in 1995. So this is the you can see in 1999, I did 24 cases with this approach, this basal approach. This is the root of zygoma.
Okay, Sam, let's try it again.
This is the condyle, this is the external canal, and mastectomy. This was the extended lateral basal
Sam,
Am I audible? Am I audible now?
Oh, there you go. There you go.
Yeah. Can you see me?
Yeah, I can see you. Hey, listen,
Yeah.
Sam, I just did this at the last minute. For some reason, I ran across your name and I was thinking about, hey, let's do a neurotrauma for residents in India. We won't get many people, but it's just an idea I'm floating. You know what I mean?
Yeah.
Yeah, we'll give it a shot. We'll give it a shot. And we make it a few people. So anyways, you're doing interesting stuff. You work in a big trauma center, right?
Yeah.
Yeah, I'm sure you have lots of stories to tell.
Yeah.
Like every doctor, but more so with neurotrauma. It's just an exciting field, period. But where are you from? You're from India, obviously. Where are you from in India? Chennai?
I'm from Chennai.
Oh, you're from there. Do you know who's that older gentleman, the pediatric surgeon? You know Goel, of course. Neo Pujari, Chandra.
Oh, no.
Yeah,
Ankush Chandra. Dr. Ankush Chandra.
Chandra, he's a big pediatric neurosurgeon from Chennai.
Oh, okay. Yeah, I think I know him. I think I've seen him also.
Oh, he's a great guy. I've been doing webinars with him for years. And same with Goel, I've been doing him for years. But so what year resident are you?
I'm actually in my second year.
Well, that's okay. That's okay. You have a lot
and it's
to tell.
basically neurotrauma come neurocritical care posting right now. As of now, like 6 months of neurotrauma with neurocritical care. So it has both mixed neurotrauma as well as neurocritical care topics.
So you spend a time in the least favorite part of the hospital, the ICU. As part of the job, you like the OR, like every neurosurgeon. That's your place, right?
Yeah.
Yeah. And I'm sure you get a lot of experience where you're at, right? Are you getting a lot of experience, hands-on experience?
A lot. Like we have actually a 30-bedded neurotrauma ICU, so just 10 beds for pediatric as well, and we usually get around like 40 to 50 cases per month, and we used to do all the procedures like by ourselves, like cystinostomy. Even as a second year resident, they'll give full hands-on for all the emergency procedures, as well as any coiling also we get to do it. Even though it's a very less resource setting, like any aneurysmal coiling or anything, we used to do that.
Yeah, so you have a senior overseeing, right? They senior oversees you. It comes in and checks on you. How does that work?
Yeah. Actually, I'm working under Dr. Matthew Joseph. So he's a former HOD of neurocritical care and neurosurgery, and he always comes and checks up on us like thrice in a day. It's a team of three, like one second year and one first year, as well as one SR will be there, which is a senior resident, or in the US they call it chief resident. Yeah.
So he'll come and check on you.
Yeah. So it is sometimes fun, sometimes it is very hard, because the too much of patients will come at a time. Sometimes it will be flooded, the IC will be flooded. You won't be having any time to do even small things. So yeah, but it's fun.
How many residents in your program?
There is something called 3 years and 2 year residency. So I'm in my third year. Then I have to do 3 more years in neurosurgery. So that has to be at least 6 years.
6 years.
So there are three residents as of now in 3 year program.
Yeah, when I was, I almost did a neurosurgery residency. They wanted me to at my hospital. The neurosurgery residents liked me, and they say, "Oh man, don't go into orthopedics, go into neurosurgery." But I didn't do it. I just didn't like the OR enough. I didn't have the fire. You know what I mean? Because I think to be a neurosurgeon, you have to have kind of a fire to be a neurosurgeon, and it can be nothing else. So, which is right. I mean, that's the way it should be. But anyways, so you spend a lot of time in the hospital. Obviously, that's a dumb question.
Yeah, actually, I took off today, so that's why I can talk to you, or else I wouldn't.
Oh,
I wouldn't
good.
have enough time to talk to you.
Good. Good. Okay, we'll be starting in about 5 minutes. Okay. Tell your buddies to come. I'll be back. Okay.
Can I share?
No, not yet. No, not yet. Let's wait 5 minutes. Okay, or 6 minutes.
Can I switch off my video? So
yeah, I'll show. I
think,
know you probably don't know this. At the bottom of your screen.
Yeah, no, I know. I can switch off my
yeah. You can switch it on and off as you want. But a lot of times I have to do last minute promotional stuff, which I'm going to do now. I go to WhatsApp, and you know that what that is.
Question is, you can harm the person also, and that we have to understand. We are not gods, we are not.
So give me about 5 minutes to do that.
We can create neurological hemispheric deficit. This was another tumor. You see, there are two types of meningioma and two histological two types. So this was syncytial type, this was meningiomatous meningioma. So these two meningiomas in one meningioma. In general, tumors which involve the cavernous sinus are histologically more aggressive tumors. And this was another tumor which I operated several years ago, maybe 1999 or 1998. This patient developed severe hemispheric deficit hemiparesis. And this changed my life after this operation. You can see a beautiful resection so many years ago, but developed hemiparesis, and that changed my life. And I realized that how to save the perforator, how to be at the same distance from a perforator, how not to handle the cranial nerves more. Now my policy is, if I have to dissect and handle the cranial nerves for more than 10 minutes, I will leave that tumor behind. If I have to dissect near a perforator for more than 4 or 5 or 6 minutes, I will not dissect. I will leave the tumor behind. I will not take the risk. And this information was given to me by this patient. He's still alive, this guy, but has hemiparesis, but he's able to conduct himself. This lady, another one, somebody had tried to expose this tumor. He removed the temporal brain. So the whole thing was, when I did, was open for me, directly hit the tumor and removed. And this patient had developed hemiparesis much before I touched and much before I handled the tumor. So these tumors can be, I used to do middle fossa approach on a regular basis. This tumor, my indication was middle fossa approach. This posterior clinoid meningioma and pictoclival meningioma. My approach was middle fossa approach, and not only this anastosis of the posterior clinoid. When there is anastosis, the tumors are more firm and more gritty and more stuck to the adjoining vessels, more dangerous and more difficult. This was another pictoclival kind of meningioma. This was another in a very prominent person where I removed and left some from the middle fossa tumor. To go down to the pontomedullary junction can become difficult even if you have a big exposure. So there was some residue here. But then, at that time, we never used to talk about any gamma knife or anything.
In just a few minutes, Sam. We'll wait a few minutes, Sam, okay?
Yeah,
Like I say, this is the last minute thing I did, I promoted. Did you see my promotion? Oh, I have YouTube on, I guess. Hold on, I'm Uh, Sam?
Yeah, tell me. Hello.
Yeah, can you hear me?
Yeah, tell me.
Yeah, Sam, why don't we go ahead and start? We may have a few people coming. Uh, do you want to do that?
Yeah, sure.
Yeah, okay. Let me get one last thing done. Second year resident, right? Okay, let's go ahead. This will be like a rehearsal. Okay, 10, 9, 8, 7, 6, 5. Sam, can you put your photo on? I gotta introduce your face. Sam,
Uh,
your picture's
yeah, yeah,
out.
yeah.
I need to see that picture.
Okay. I'll send you the picture or I'll switch on the
No,
video.
there you go. That's all I need. You need to be on camera. Okay, 10,
Okay.
9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. We have the pleasure of having Sam Benniel. He's a neurosurgical resident from Chennai, second year, and he's going to be talking about whatever he wants to talk about, whatever interesting things he's run across. And we didn't have much time to promote, but people will come in eventually. And it will be on the internet. It'll be live on YouTube. Welcome, Sam. It's all yours.
Thanks, John. Thanks for inviting me for this webinar, actually. And I'll just say some few interesting things in neurotrauma which I have encountered in CMC. And can I share the screen?
Sure. Okay. Okay.
One second.
Okay. Make that full screen there. There you go. Make that full screen. You know how to do that, Sam? Make it presentation mode. Okay,
Okay.
perfect, Sam.
Yeah, sure. Okay, my name is Sam, and I'm a senior house surgeon in Christian Medical College under neurotrauma. I'll just tell you guys some interesting things which I've encountered in neurotrauma ICU. And this is case number one, which is a 17-year-old male. His name is Srinivasan. Actually, he's a two-wheeler versus four-wheeler under the influence, and which is not wearing helmet. And the GCS was 7/15, and he was presented with the triad of death, which is disseminated intravascular coagulopathy, acidosis, and hypothermia. So usually, when there is a triad of death, the patients will 90%, 90 to 95%, the patients will die. But surprisingly, he survived. We did TEG. He lost around 2.5 liters of blood loss in draw, and which is a huge thing. And we transfused around 8 FFPs, 4 liters of RCs, and two bags of uh, platelets as well. And see, this is him actually. Like I couldn't get a good picture of him actually. So I remember taking a picture of the bleeding. So since it was a short period, I couldn't get all the labs and everything. So this is one interesting case, which is no one usually survives the triad of death, but this guy survived, and he even though the score is low on discharge, like it is actually a big thing. That is one interesting case I would like to share with you guys. Um, and the second case, which is very actually, I think this everyone would have encountered. Most of the patients with DII usually they don't survive. Like they don't show proof. Like imminent progression in prognosis. But this patient, like he's also a male, and he presented with DII with no midline shift, and but his disease improved drastically within a period of month. And we don't know. Even MRI showed punctate hemorrhages in the labs and all. So, but he improved very well. And so this is one other interesting case which I couldn't get the images. I'll show the subsequent cases. Like I have all the images. So this is one interesting case. I'll show you one video actually. Okay. Can you see? Can you see the video?
Yes, perfect.
Yeah, yeah. So this is one interesting case. Actually, the patient presented with heart failure with a right atrial myxoma, which is extending into the ventricle of the heart. So the patient had a score. Initial score was E2, V2, M3. So we intubated him and we took him to surgery for surgery. The CT wise, it is actually bitemporal basifrontal contusions as well as weather. And for intra, there were around like 1.5 liters of blood loss. But he did well. Surprisingly, like there was no emboli post surgery because we expected emboli because it was a huge atrial myxoma which usually causes emboli, um, and so he actually survived. So that is a huge thing. And one more thing, he also had cerebral T waves, which everyone would have encountered. That is T wave inversions, so we send enzymes and everything. We usually confuse it with MI, but yeah, due to the increased ICP, he had T wave inversions, and which is contrary to the atrial myxoma. So he survived with the disease of actually 14 by 15. Yeah, he revived and he's fine now. So that is one more the interesting case I just wanted to share with you guys. And one more thing I just wanted to share with you guys is this one, which is traumatic SAH. In a traumatic SAH patient, we usually check on the third day if there is a vasospasm. The prognosis is usually going to be poor. So this is one such guy who's increased, like it was a diffused SAH in the perimesencephalic space as well as in the bifrontal sulcal spaces. There were SAH with them, but contrary to that, that TCD profile, everything was normal. The pulsatility index was 1.36, which is on the borderline on the limit, and also which is done by two people, which is one. This was done by me, and this one was done by my colleague. So which was 0.82. Since ultrasound, always has an interobservable variability. So this showed the patient doesn't have any vasospasm. But surprisingly, even though he didn't have any signs of headache or anything, like no, he actually improved very, very well, even in the next 1 month post-op period. But he had a vasospasm when we did a DSA. Actually, we did a DSA for a study purpose. There's one more study going on whether intraarterial verapamil can be used in vasospasm of SAH versus in nimodipine. So we did during that study, we found that he's having severe vasospasm, but he's not showing any symptoms. So it is an incidental finding of vasospasm. So you should always go around with a traumatic vasospasm. It should always be multimodal. We usually use TCD to roll out the vasospasm in a neurotrauma ICU as a critical care or a neurosurgeon. But it's better when compared to aneurysmal SAH. Traumatic SAH is much more different than an aneurysmal SAH. So it is always better to go with the TCD as well as DSA rather than TCD alone. And then another thing, this is one particular topic I am very much interested in. Actually, we did one retrospective analysis as well as a prospective study that yearly tracheostomy, irrespective of the CT findings, has a better prognosis in patients with neurotrauma. Especially, they have a shorter hospital stay and reduced risk of aspiration and post-trauma infections. So this is one such patient actually. This is one such patient. We intubated him on the day two of trauma. He was presented with a low score, but we managed conservatively for the past two days actually. Yeah, he was admitted 4 days back, and we intubated him 2 days later, and we tracheostomized on the day we intubated him because we believe early tracheostomy leads to early out of hospital. Okay, so actually he's free today. He's getting discharged today because like that improved so much. Like we don't know the relation. We don't know how to put up the question also because we're just trying to find out the question. Either we can put it as a prophylactic tracheostomy or whether it is a preventive tracheostomy. We don't know because since hypoxia, hypoperfusion, these are all the one of the more major drivers for secondary brain injury. So this can prevent hypoxia, which can be very, very helpful in preventing secondary brain injury in a traumatic brain injury patient. So this is one more interesting case which we have done, and the study is still going. This is what I'm saying. With a prophylactic tracheostomy, which is an invasive procedure, compared to an endotracheal intubation. Endotracheal intubation, we don't put an incision or we don't do anything. In tracheostomy, you have to put an incision, you have to get the consent, and there are a lot of ethical dilemmas still there. But it will be very helpful. We observed over 100 patients. Out of 60 patients had a better outcome. So maybe that we can do further study and we can relate to that. And this is just, I just wanted to add on neurocritical care part. We always think that the map is very, very important in the neurotrauma patients. We always put a NORAD or a DRE as much as possible to maintain the map to maintain the perfusion. As I said before, hypoxia and hypoperfusion has a huge role on maintaining ICP as well as CPP. And this is one more thing, which another potential research topic which we are interested in. Actually, there is no glycemic cutoff for traumatic brain injury. We see most of the patients go into DKA in neurotrauma ICU. We are thinking like there is no particular cutoff or in any clinical trials which I have ever done for the sugar control in neurotrauma patients because when the sugar goes very low, less than 140, the patient has a higher chance of ischemia in a especially in basifrontal contusions as well as in traumatic SAH. So uh, our guidelines, so like CMC always believes that we should put up some guidelines, do some researches based on whatever we can do to minimize the secondary brain injury. So this is one more research we are actually it's currently undergoing. Like we're planning to do an RCT in particularly in neurotrauma patients to maintain the glucose between 140 to 160. So these are all done in a normal critical care patients, not specifically oriented for neurotrauma patients. So which may be or may not be helpful. And there are also adjunctive, like studies which have shown SGLT2 inhibitors. We always use mannitol and hypertonic saline as an osmotherapy for patients with neurotrauma to reduce the ICP. But there is one more study which has proved recently. Actually, it is SGLT2 inhibitors in neurotrauma, which has been very, very helpful. We already tried it in retrospectively as well as prospectively. We're doing one more study. Actually, Dr. Vivek Joseph, he's currently presiding that study, SGLT2 inhibitors in neurotrauma patients, which showing promising recovery because it also increases the sodium levels as well as it also decreases the glucose levels. So which will be very, very helpful in neurotrauma patients, but no one has ever done it. The last study, which was actually a small, it is not an actual prospective pilot study, which was done in Iran, and they included only 30 patients when the outcome was 50%. It was positive. So I'm just putting this will be a gist of like what we can do with glucose in neurotrauma patients, because it can very well help with preventing secondary brain injury. So, which is much more important in a neurotrauma patient. And one more thing, this patient infection in neurotrauma, especially in India, like everyone has TB. Literally everyone has TB. So one patient came in with TB and GCS of like 9/15. We don't know it's TB. I didn't check his X-ray and all. I went without the mask and gloves and everything. And then I checked. I did an echo because like whenever we receive a patient in the ER, so we need to do an echo to rule out any other comorbids or anything. So I did an echo and I did a TCT. So when I did an echo, the heart was on the right side, right aortic area. And so see, this is the X-ray actually that shows TB. This is the right upper lobe patch is also there. So after that, like 2 days later, his rapid TB test came positive, and I took prophylactic measures as well. So it's better to prevent yourself from getting infections rather than indulging in like saving traumatic patients. First, always save yourself. That also I just want to. And the last, this is very interesting. Cancer in neurotrauma. Since neurotrauma is always associated with you know uh, it's always associated with inflammation, and it always activates inflammatory mediators. It can also activate the cancer which is lying dormant. So this is one such rare case. His name is I can't reveal the name. So it's a very interesting case. He's a RTA, a two-wheeler versus four-wheeler. So he's a farmer. While riding back, he was hit by a car, and not under the influence. And surprisingly, like his GCS never improved. Like he presented with GCS of 13/15, then his GCS dropped to 9/15, and he never improved after that. And we were thinking of some other source why the GCS was not improving. And we did an MRI after 1 week, and it showed a cerebellar stroke, and as well as demyelination in the spinal cord. And we were thinking, like, what could be the reason? What could be the reason for demyelination and stroke? Especially the previous CT showed basic frontal contusions, but why he had that cerebellar stroke, we don't know. Like, we didn't evaluate well as well. So we checked for other sources, and then we did a local examination after actually nearly 3 weeks, 3 to 4 weeks. And this was, we found it, and we did a biopsy. It showed a squamous cell carcinoma, which got activated due to the inflammatory mediators produced by the trauma. So this has never been proven, but we understood, like, because he was never found to have cancer. Even he did test 1 month back, which was negative for a cancer workup. So it was very interesting case actually. So this is one rare case which you can like publish it. We are actually publishing it. That is one. And the last, and this one everyone knows it actually, talk and die syndrome. So over an year, I think period of 10 years from 2013 to 2025, more than 12 years. Yeah, 12 years. We have collected over 100 patients with talk and die, with most of the patients with GCS of around 14/15 to 15/15, with the minimal scan, not even a much bigger lesions, and still they died. And we didn't know the reason. We did a analysis, and it showed if you use a multimodal imaging, so the people who had a better, like prognosis, with the people who didn't have the better prognosis in talk and eye. That means, like, we compared those with people who died with good GCS, people who didn't die with good GCS but had a score drop. We actually did a multimodal imaging. Basically, like, we did CT, MRI, and CT/CD as well as ONST. But in people who had talk and die, we didn't do everything. We just did CT, a baseline CT, because as a neurosurgeons, we always, like, check for the CT. But if the CT is okay, then we'll usually leave it to the neurology. We don't look at the neurocritical part. So even if the patient has a good GCS, it's always, if you want to prevent a Token-Dye syndrome, it's better to do ONST, TCD as well as MRI. But MRI is pretty costly. ONST and TCD is, you can do it hands-on with an ultrasound. So it's better to do it to prevent Token-Dye. That's we found it retrospectively. So that's one more thing. That's all actually. Thank you so much. Actually, I just want to thank you, my mentors, Dr. Matthew Joseph, who's a professor of neurosurgery from CMC, and Dr. Shalini Nair, and head of neurosurgery. Thank you.
Okay, very good. Thank you very much. I see Kumar Ab and Ab. How you doing, Kumar? You came to join us. Okay, very good. Any questions from the panelists? You know, I'm not a neurosurgeon, Sam, but I see the ultrasound is being used a lot more in trauma, right?
Yeah.
That was never
Yeah.
used when I was in training. That was never. I don't think it was even used in neurosurgery. Maybe they improved the technology or whatever.
It's actually to prevent it. Like this is very upcoming. There is also a lot of studies about contrast enhanced ultrasound to prevent further vasospasm in a traumatic brain injury, which can prevent further deaths in traumatic brain injury. That is also one more study which is uh, potential topic. Actually, I'm much interested into neurotrauma research, so I have to look up through all these topics and everything. So, whether is there any other new ways to improve it? So, this is one more budding topic: contrast enhanced ultrasound. So, there are a lot of ways, like ONST optic Naoshi diameter has been done very frequently. Like nearly most of the residents, not just residents, like even an MBBS graduate who's like a person from medical school or learning it in CMC, because this is very, very important, and this can actually prevent you from. It is a very cost-effective method to decide on CT as well. If you need a repeat CT, we usually do an ONST and TCD to see whether there is actually something happening in the brain. So then we go for the CT, because CT is pretty costly. Even in India, CT is around, CT brain is around 5K, which is very costly for poor people. So it is a cost-effective method as well as a very efficient method um, for a better prognosis.
Can ultrasound actually take the place of CT in rural settings? Like some centers, as you know, don't have CAT scan. They don't have, and they have to ship people. Would an ultrasound studies before they're transferred, would that be advisable or no, just transfer?
I can't hear you. Hello, I didn't get it.
Oh, okay. If you have a trauma patient in a rural hospital that maybe doesn't even have a CAT scan, can you do ultrasounds? Will that detect the major problems in neurosurgery?
Yeah, you can. But the thing is, like, you can detect the most imminent problems rather than the most foregoing problems. Like, for example, you can detect vasospasm with TCD, like transcranial Doppler. You can detect vasospasm. You can detect SAH. You can detect EDH, and STH you can detect provided, but you won't know where the STH is. Like, for example, you can do the TCD in submandibular view, transtemporal view, as well as in the suboccipital view. So you can detect in these locations. Not always you can rule out the particular hemorrhage, especially if it is in the brainstem region and all. Like it is highly unlikely to be found. So it can be cost-effective method. Maybe it can be a point of care ultrasound can be used in a warfare. It can be really helpful. It can be really helpful, whether for triaging, whether the patient needs urgent care. It can be really helpful.
Okay, so
Even
go ahead.
Yeah.
Go ahead.
No. Even a contrast enhanced ultrasound has been shown promising studies. There are a lot of studies which shows a microcirculation as well, like which relation between contrast enhanced ultrasound and detection of microcirculation. So microcirculation, which has been more important in tumor, stroke, as well as in TBI. So it can also helpful, but we don't know the extent yet because the only preliminary studies have shown it. But in clinical studies, like we need to do it. I feel like we need to do it much more into it. Maybe it can be helpful. Contrast enhanced ultrasound can be helpful in detecting severity in TBI.
So
That's,
you're going into neurosurgery research next year?
yeah, I'm much into neurosurgery, especially in
Oh,
trauma.
cool. Oh, good, good. That'll be an exciting field, and you'll be studying things like that. The expanding use of ultrasound in neurosurgical problems. That was news to me when I started doing these webcasts about neurosurgeons doing ultrasound, because we were always taught that it couldn't penetrate the bone, the ultrasound. They must have made it more powerful or something. Now, that's a one-year fellowship, neurosurgical research.
No. I'm currently doing my senior house surgeonship in CMC. So it is like a 2 year bond. Then I have to finish my surgical residency in 10 years. So over a period of 14 years, I'll be in CMC
Wow. Wow.
to finish my
Wow.
residency. So after 14 years, I'll become a neurosurgeon.
Wow.
This is
That's
my second
about,
year.
how old are you? You're young, right? How
I'm
old are you?
I'm I'm 24.
Oh, you'll have lots of time. You'll have lots of time, and you'll be very well trained. Okay, very good. I wish I had more neurosurgeons here to kind of ask your pointed questions. We'll keep in touch and we'll chat after we finish. So thank you, Sam. Stick around. I'm just going to
Thank you.
I'm going to turn this off now. We're going to end now. Thank you.
Thank you so much.
Okay, Sam, we're off the air. Sam, I really apologize because I made a mistake and I put this webcast against Dr. Goel has a conference now. And he draws a lot of people, and I broadcast him a lot. I didn't check he's running at the same time, and he's taking, I think, most of the audience. So it was my programming fault. I would fire myself for like a TV programmer has to think about the times. This is a good time for the world, actually, because it's 8 o'clock in India, but it's 10:30 in America. It's doable, but I shouldn't have put it against Dr. Goel, the king. So, but that's okay. I learned too. Okay, Sam, thank you very much.
Okay.
Well, at least
Okay.
this will be on the internet. This will be in your resume, your video resume. It'll be online, and I'll send you the link. Okay.
Okay.
So put it in your portfolio.
Okay.
Okay, Sam. Thank you.
Keep in touch. Thank you.
Okay. Bye-bye. Okay.